Anatomy is the roadmap of the body. It is important to learn anatomy before you can understand how the body functions. So that's what we're going to do, talk about anatomy, the bite, and jaw alignment. Whenever I am examining someone for the first time, I am looking at three parts. The TMJ, which are the joints, the dental occlusion, which is the bite and how the teeth mesh, and the alignment of the upper and lower jaw bones. I'm evaluating them as individual structures, as well as how they align and interact with each other. We teach our patients that the jaw functions analogous to a door. A well-hung door should be well aligned so that it easily closes with a gentle push with one finger. This means the hinges, the frame, and the lock are properly aligned and work in harmony. A door can have many problems involving the hinges, frame, and/or lock. The door does not close, and even the lock and door knob have been replaced. Observe that there are even two discarded doors in the front room. This door has problems with all its parts. There can be three different categories of door problems. There may be misalignment of the frame, may be a loose hinges, or the lock or doorknob may be misaligned. Attempts to close or align the door by pulling on it or jiggling it will not fix the underlying structural problem, but will cause unfavorable forces and possibly damage parts of the door. We tell patients that we look at their face and jaw in a similar manner as evaluating a door. When there are problems with the structural or alignment of the joints, bones, and teeth, then major dysfunction and degeneration occurs. We often see problems with not only one, but usually two or all three structures at the same time. Let's look at this animation of a normal TMJ movement. When the jaw opens and closes, the movement should be smooth, quiet, and free of pain. Between the lower jaw, called the mandible, and the socket, called the glenoid fossa of the temporal bone, there's a disc. The disc functions as a sliding, lubricating shock absorber between the bones as the jaw opens and closes. When the jaw opens, there is a muscle that pulls both the bone and the disc forward. When the jaw closes, that muscle relaxes while the stronger chewing muscles move the bone back into the socket. The disc, however, is pulled back into the socket by an elastic ligament called the retrodiscal ligament. Think of the retrodiscal ligament like a rubber band that stretches and contracts as the jaw opens and closes. Within the retrodiscal or behind the disc ligament are elastic fibers and cells that produce synovial fluid that lubricates and nourishes the joint. Also, the majority of nerves within the joint are located within the retrodiscal ligament. These nerves don't sense hot, cold, sharp, or dull feelings, but only perceive pain. So if these tissues are stretched and torn, then strain, sprain, and swelling stimulates the nerves and causes pain within the joint. The jaw is moved by four pairs of muscles called the muscles of mastication. These are the chewing muscles. They attach to each side of the mandible. Three pairs of muscles close the jaw, and one pair opens the jaw. The lateral pterygoid muscles open the jaw by pulling the bone and disc forward, like you saw in the animation a moment ago. The other three muscles close the jaw. They are very strong and larger than the lateral pterygoid muscle that opens the jaw. The masseter and medial pterygoid muscles wrap around the back and lower part of the mandible, creating a sling called the masseteric sling. The masseteric sling, along with the temporalis muscle, which is in front of the mandible, along the sides of the head, strongly close the jaw so we can chew even crunchy and chewy foods. The muscles of mastication that close the jaw attach to the outside, inside, and front surfaces of the mandible. The mandibular condyles are the hinges of jaw closure. So when the jaw closes, these strong muscles pull the jaw upward until the teeth touch. Note that on each side there are the three masticatory muscles, the temporalis, the medial pterygoid, and the masseter, that on either side of the mandible pull it upward and are very strong. As mentioned earlier, the lateral pterygoid muscles open the jaw. Note the alignment of the muscle fibers that are positioned to pull the jaw forward, but also towards the midline. These muscles also move the jaw side to side. When only the right lateral pterygoid contracts, the jaw will move to the left as the jaw rotates on the left condyle and vice versa. When the jaw protrudes, both muscles pull the condyles forward. This is another cadaver dissection that shows TMJ anatomy. There are several layers of tissue that cover the TMJ. The TMJ is located in front of the ear canal, which is called the external auditory canal. The sensory or feeling nerves that innervate the retrodiscal ligament also innervate the front one half of the external auditory canal. This is why TMJ pain can seem like ear pain. Immediately under the skin is the superficial or subcutaneous fascia. Within this layer are fat and other tissue cells that make our skin loose and movable with our fingers. Also located in the region are tiny nerves that supply feeling to the skin, as well as other tiny nerves to the sweat and oil glands of our skin. The frontal branch of the facial nerve, which moves our muscles of facial expression, including the forehead muscles, is within the fascia superficial to the TMJ. Under the superficial fascia is another layer of firm tissue called the superficial temporalis fascia. This tissue covers the temporalis muscle and extends over the TMJ. The TMJ capsule is the ligament that envelops the TMJ. Exposed here is the top of the mandibular condyle. It is covered with a special layer of cartilage called fibrocartilage. Fibrocartilage is shiny, smooth, and very strong. It is the same type of tissue found on the end of a chicken drumstick. Here the fascia and TMJ ligament tissues have been removed to expose the mandibular condyle. Also, the facial nerve that innervates the muscles of facial expression from the forehead to the upper neck has been preserved. Note how close the facial nerve is to the TMJ. This is a great picture of the TMJ disc. Part of the temporal bone has been removed to expose the TMJ. The lateral pterygoid muscle attaches to the front or anterior portion of the disc. There are two parts of the lateral pterygoid muscle called bellies. The retrodiscal ligament connects the back of the disc to the temporal bone in front of the ear canal. You can also see the retromandibular vein and maxillary artery in this picture. The TMJ is very vascular and heals very well. When the tissues are injured and displaced, they will heal, but not in the location or shape that is beneficial to function. The lateral pterygoid muscle is small and deeply surrounded by other tissues posterior or behind the upper jaw. The concept of being able to directly palpate or feel the lateral pterygoid muscle is a bit of a fantasy. The two bellies of the lateral pterygoid muscle have different actions. The larger inferior belly attaches to the mandibular condyle and opens the jaw during opening by pulling the condyle forward. The smaller superior belly attaches to the disc and pulls the disc forward during jaw opening. Also, the superior belly contracts immediately at jaw closing, which pulls the disc forward. This last muscle contraction stabilizes the position of the disc in a healthy joint, but contributes to disc dislocation in a TMJ that has a stretched or torn retrodiscal ligament. There are three important structures within the retrodiscal ligament: elastic fibers, sensory or feeling nerves, and cells that produce synovial fluid that lubricates and nourishes the joint. The 2 points here: first, the TMJ will heal because of these tissues, and again, the lateral pterygoid muscle is small and deeply surrounded, so you really can't feel it. The right image shows a section disc as it rests on top of the condyle. Note that the thinnest portion of the disc on the anterior or front top of the condyle, this is where the greatest load-bearing forces occur during jaw movement, and this is why the disc is thin in this area. The top of the condyle is covered by fibrocartilage. Collagen microfibers weave through the cartilage, making it very strong and resilient. These circled areas indicate that the disc does not attach on the top of the condyle, but actually only attaches on the inside, outside surfaces, and acts like a hinge or a fulcrum in this area. That is, it rotates forward and backward on top of the condyle. This is a frontal view of the TMJ. The disc attaches to the sides of the condyle with small ligaments that hold the disc into the top of the condyle while the jaw moves. The TMJ capsule is a thin ligament between the mandibular condyle and the temporal bone that envelops the TMJ. Let's get oriented and note the histology or microscopic tissues of the TMJ. The disc, or dense fibrous connective tissue, is what the disc is made of. The disc is not cartilage. The only cartilage in the joint is fibrocartilage, which is very strong and lines the glenoid fossa of the temporal bone and the superior or top surface of the condyle. Both the disc and fibrocartilage receive their nourishment from the synovial fluid that is within the superior and inferior joint spaces, that is, the spaces between the discs and the bones. The synovial fluid is produced within the synovial tissue lining of the TMJ capsule and especially within the cells in the retrodiscal ligament. This means that joint movement is essential for synovial fluid circulation and TMJ health. The disc is dense, fibrous connective tissue. The fibrocartilage, again, covers the condyle and articular surfaces of the joint or the socket part. So let's put this together. The disc is a sliding shock absorber between the fibrocartilage surfaces of the mandibular condyle and the glenoid fossa of the temporal bone. The lateral pterygoid muscle pulls the condyle and disc forward during jaw opening. The three other muscles of mastication close the jaw while the disc is pulled back by the retrodiscal ligament. Jaw movement should be smooth, quiet, and free of pain. Noise, pain, and limited jaw opening often indicate that damage has occurred to the TMJ tissues. This is a TMJ MRI. MRI means magnetic resonance image. It is a gigantic magnet that measures the electrical signal in water. This means that light areas contain more water than darker areas. A movie of the jaw movement is made when multiple images of the MRI during jaw opening are put together and played in a sequence. This is a normal TMJ MRI that shows a normal condyle during jaw opening and closing. Notice the gray disc remains between the condyle and the fossa of the temporal bone during jaw movements. When the jaw moves, the disc looks like a small bow tie on top of the condyle. Most humans open their jaws 40 to 60 millimeters. That's about 2 inches. But some people can open much wider. The largest opening I've seen in a normal TMJ is over 90 millimeters. There may be abnormalities such as disc displacement if jaw opening is limited or painful or noisy, or even other problems such as difficulty to open and chew when there have been damages to the TMJ ligaments and discs. When the jaw closes, the teeth should evenly mesh with midline symmetry. The back teeth should touch with the upper front incisor teeth slightly forward of the lower incisors. This bite, which is called a dental occlusion, the bite should align with the TMJ hinge. When the jaw protrudes, then only the incisal edges should touch together and the rest of the bite should be open. During left and right jaw movements, only the canine or eye teeth should touch on one side and the rest of the bite should be open. These tooth alignments during chewing, when the teeth mesh the most, must correspond with the hinge axis of jaw closure. These are called the principles of occlusion. They are the foundation for normal function of the jaw, bones, and bite. As you may see, TMJ disorders are complicated and involve problems not just with the joints, but also with the way the teeth come together and the alignment between the upper and lower jaws. When the key structures, that is the bones, the bite, and the teeth are properly aligned and each is in good condition, then long-term stability of jaw function and health is optimized. And again, what we want to see is intermeshing of the teeth that coincides with the hinge axis of jaw closure.